Thanks very much, Solon. The
Just a note, let's press the button.
This is just an overview and a reminder of the basic concepts of retinal detachment surgery and also vitreous hemorrhage. So you're all aware there's three types of retinal detachments. What we commonly call retinal detachment is, of course, rhegmatogenous retinal detachments. Tractional retinal detachments we see most commonly in diabetes and sometimes after trauma, and exudative retinal detachments in uveitic conditions. In this talk, I'll just, because of time, talk about rhegmatogenous retinal detachments, which is, implies there's a tear from rhegma. And the break is the cause. This momentous concept was found by Gonan. And of course, we're all familiar with both atrophic holes, but more importantly, U-tears. And not only is the break the cause, but it usually requires some traction, which accounts for why some atrophic holes don't progress, but most U-tears do, because there's a combination of break and traction. And it's interesting that in 1920, Gonan published this to great disbelief, so he wasn't universally believed, but that would make next year the 100th anniversary of the origin of modern retinal detachment repair. And just to remind you, we've got it easy now with small gauge surgery, wide angle viewing systems. Here he would heat up a bent needle and stick it into the eye while looking and seal the hole on itself, not to anything else, but just to crumple up the hole, and he still got them to work. What about the cause of these breaks? Of course, we're all familiar with the posterior vitreous detachment, or as David would say, posterior vitreous separation. Trauma, pathology, so we see this where the retina starts to disintegrate, CMV and ARN, and degenerations, especially myopic round holes in lattice and other degenerations. Finally, we see traction eventually getting so strong that it breaks the retina, either in diabetes, in macular hole in some cases, and in PVR. PVD is by far the most common. That's the one we'll all come across. Why does PVD cause a retinal detachment or a tear? It's because there are particular points at which the vitreous is abnormally stuck strongly to the retina, and they are the disc, but of course this is separated early, the vessels, which sometimes lead to the hemorrhage associated with PVD, but more importantly, the vitreous base. And at the vitreous base, it's impossible to separate the retina and vitreous, and this is the point at which we get retinal tears. This is heightened, of course, by pathology, where the vitreous is more attached to thin retina, which is the configuration of lattice. And what we also must remember, it's not just a passive thing, but that once the vitreous is separated, as in this video, it is actually flicked like a whip at very high speed every time there's a saccade. And the point of attachment is, in fact, the force which is implied to that point. You can see it here when it flicks, is very, very high, sufficient to tear the retina. What about assessments? Well, of course, if you know that the most common origin of the tear is posterior vitreous detachment, you need to identify that. You need to find the breaks, although these days with modern vitrectomy surgery, that's becoming a little bit less critical than from old buckling surgery. And of course, the state of the fellow eye, because it always feels bad to treat the detachment on the right eye and miss the tear or early detachment on the left. You're all familiar with looking at the posterior vitreous detachment and the Weiss ring, which most of us feel is a good sign of it, but is not universal. But here's some examples of the Weiss ring. And also, you can look for the posterior vitreous face, but even someone who's done vitreoretinal surgery and looked at lots of detachments couldn't tell you hand on heart every time they see the posterior vitreous face, but you're supposed to look for it and see if it's come off anyway. Pigment's a much more important sign. Everyone's looked in the vitreous to see whether there's abnormal pigmentation, the famous Schaeffer's sign, and it's well documented. This is the important paper by Vaughan Tanner, which shows that in 200 eyes presenting with an acute PVD, 25 were found to have retinal breaks, of which 23 had pigment. And in 115 eyes presenting with retinal detachment repair, 111 out of 115 had PVD and Schaeffer's positive. So it's quite a good sign. So if you do see the pigment, look again if you still haven't found the tear. Now, it's not impossible, of course, to get pigment and no tear, but it's something that should alert you to look very closely. to look. Examination of the slit lamp is good. Now with better and better contact lenses and better wide field lenses, we can see almost up to the aura, so most breaks are now visible. But don't forget, and you shouldn't lose the skill of indirect ophthalmoscopy with indentation, because it allows you both a more peripheral view in every case, as well as a dynamic rolling view, which often opens small and invisible tears, and sometimes ultrasound, usually when there's hemorrhage. Linkoff's rules, I don't think anyone, even trainee retinal surgeons, can now draw all of the Linkoff diagrams, but just for historical purposes, the Linkoff rules in a phakic eye, which hadn't had any previous surgery of any sort, you can pretty well identify where the breaks are depending on where the fluid is. It was useful just in general when you couldn't find them, but also it's useful when the pupil is small, because you might think that this configuration suggests that there's a tear inferiorly, though Linkoff's rules would tell you that because of this sinus, that in fact, and the recurved edges, that the tear is at the top, and you would know that even before you dilated the pupil. So we don't need these things to remind us of all of those. And so once again here, this configuration is of an inferior detachment, inferior tear. This is a configuration of a superior tear, and we learned that from Linkoff. What about breaks? Not always easy to find them. Do you have to find them? It's usually useful to find them, and if you can't find them, you need to just have a little think about it at the back of your mind whether this could be a different type of detachment. Pigment helps, so no break but pigment makes you feel like you're just missing it. Chronicity, signs of subretinal change, that is subretinal bands, subretinal fibrosis usually tells you there's a break somewhere. And risk features, it's much more likely if they're a myope, have had a PVD with symptoms, that there's a break somewhere. And also, just to exclude it being a serious retinal detachment, try posturing. What we really like to do is find the breaks early and apply laser. Most people are familiar with that. Good laser around retinal tears prevents progression to retinal detachment. And the biggest problem is people having great difficulty doing the anterior margin. It's not sufficient just to do a good posterior margin and just say, well, that looks pretty good. You really do have to either go to the aura or all the way around it, or send it to someone who can. And then good laser around. This will, in the right timing, prevent retinal detachment in most cases. Of course, always tell the patients that it's a race against time, because if the fluid goes through the barrier before the 7 days it becomes strong, of course you will still get a retinal detachment. So don't tell the patient you're going to fix them up until you've got a very good retinal reaction and no subretinal fluid outside of the laser barrier. Treating breaks in lattice, which are asymptomatic, always a little bit controversial, but nonetheless, you can laser around the whole area of lattice, which decreases the risk and prevents progression of small amounts of fluid around round holes. What about the management? Well, the principles are very clear-cut. You've got to bring the tear and the retina around it in apposition to the eye wall, and then you've got to stick it together. And because our two glues, which are cryotherapy and laser, take respectively 7 to 10 days to form, you need to have some sort of clamp. And so if you think of those three things, somehow you've got to get the two things you're sticking together, and then you've got to glue them and clamp them until the glue works. And so there's two ways of doing that. You can push the retina from the inside, and that's what the vitrectomy and gas version does, or you can push the sclera from the outside, or of course you can do both. We start with scleral buckling, and the first scleral buckling happened well after Gonan's delivery of sealing the tear, which he used to do with diathermy in 1949, and he was able to apply diathermy to externally and then put the buckle on. And it may well be that it was the buckle that did the trick rather than the diathermy. It's just worth noting, in 1956, in his first publication, 515 consecutive cases with an 83% successful reattachment rate, and that hasn't improved by much over the successive 50 years. So what about scleral buckling procedure? Well, the sequence here, and this of course is not a scleral buckle, but it's the best way to show it, you've got to apply some sort of retinopexy, and this is just from a vitrectomy, but when you're looking through with your indirect ophthalmoscope, you can see the indentation and you can see the cryotherapy reaction. I know the DACE procedure usually says to drain, put air in, and then do the cryotherapy, but those first two steps, draining and putting air in, makes it very difficult to do the third step. So almost always I recommend to do the cryotherapy while the view is best. The next thing is to put in the sutures. So a few things, we measure it, and then you look out for the vortex vein, which is almost always exactly where you want to put your stitch, but nonetheless, that's life. A nice deep bite there, and this is going to hold and pull the buckle in place. And a mattress suture, of course, posteriorly goes circumferentially and anteriorly goes radially, and that's to do with the disposition of the fibers. And so we put this in place here, and I usually place the sutures and then thread the buckle. And so this is just standard. And let's move along. This is just a standard buckling position here, and there you go. That's your mattress suture. And then I'm going to show you tying up the buckle. I'm just going to advance this so even faster than it is. Make some space first. So I do the paracentesis or the drainage before you pull the buckle into indentation. So that's what that was. Actually, this is going pretty quickly. There's the buckle threaded through, and we tie a triple throw here to indent. I'm only going to do one of these. So here it is here. I need to show you because you always lose that end. So I just wanted to show that in real life. And then what I tend to do is get the assistant to make the indent here. Do not make the indent by pulling the suture. Make the indent physically and then pull the suture to that tension, and then you can close it down like this. So that gives you a nice indent. And remembering the depth of the indent is decided by the separation of the suture. So if you've got a 5 millimeter buckle and you want to indent a lot, separate the sutures over it by more than 1 millimeter on each side. That's what defines the buckle, not the size of the buckle. How far more than the width of the buckle the sutures are. And you can use a sponge or a radial thing, depending on what you want to indent. And drainage is always a mystery, but you can, in the right configuration, if you've got a high buckle and it's right where the tear is, you don't need to drain your retinal detachment and it'll go flat. So that's buckling. What about vitrectomy surgery? Most people have seen this. Step one, clear the vitreous, and you can see the retina moving, showing that the vitreous is attached to the peripheral retina. Step two, find the tear. Here it is here, usually with indentation. And of course, the view through these wide-angle viewing systems is very good, and it's much easier to find tears intraoperatively. You can drain through. You'll see the retinal detachment vanishing here, draining intraoperatively. You can apply the cryotherapy before you do the fluid gas exchange if the fluid is very thin in terms of the retinal detachment, or you can exchange with fluid. So here it is shallowing the retinal detachment, and then with air, which completely reattaches it, and it's usually easier to apply the retinopexy under air. So here's the flute going to the hole, draining the fluid from the subretinal space and replacing it with air in the vitreous cavity, and then the cryotherapy is usually much more effective under air. And so once again, apposition, the retina is pushed against the eye wall, glue, which is the cryotherapy, and then clamp, which is the gas bubble, with appropriate posturing. And depending on how likely it is to come off or how much tension it's under, you can choose air, SF6, C3F8, or silicone oil in terms of the clamp and the length of the clamp that it works. I think I won't show you what to do if you can't find the break, but most people are aware of subretinal blue, which tends to stain the break for you, but that's for a subspecialty audience. And so we come to the last question: which one do you do? Do you choose and tell your patient they're going to do a buckle or a vitrectomy? The answer is there's only one good study that looked at that, and their conclusion was that vitrectomy was superior to buckle in pseudophakic eyes, and vitrectomy was equivalent to buccal in phakic eyes. There's a bit of contention about this. The reality is most people are doing vitrectomies for virtually all cases, and the reason that this is not particularly followed is that the actual closure rates were low relative to modern closure rates using vitrectomy surgery, and therefore most of your patients, except for those with round hole detachments or young patients with chronic detachments and no PVD, most of them will end up having a vitrectomy now. In the past, competence used to be around buckling surgery, but now competence is around vitrectomy surgery in terms of training. In eyes without PVD, and that's a dialysis and round holes in myopic chronic retinal detachments, we tend to predominantly do buckles still, and in giant retinal tears versus dialysis, we'll do a vitrectomy versus a buckle. I won't go through the difference between those two, giant tears and dialysis, except to remind you that it's not about where the tear is, but the fact that wherever the tear is, it's got vitreous on its posterior and anterior edge. So you can have a torn retina, but if the vitreous completely bridges it, then you have a functional dialysis. You might say, how can that be? And that's if the tear comes from trauma rather than PVD. So that's the main difference between giant retinal tears. What about the outcomes of surgery? Primary closure is what's usually recorded. Secondary surgery from redetachment and complications we look at. And this is the UK data set, and that shows that across the UK in the National Ophthalmic data set, the closure rate with primary surgery is around 86%, and it's about the same for scleral buckling and vitrectomy. And the juniors will be pleased to note there was not a significant difference between senior and junior surgeons. In the outcomes, they're all sitting in the mid to high 80% in terms of primary reattachment. And so I just will let you know that. Secondary surgery for redetachment, why does it come off? Missed breaks, new breaks, usually N3 side breaks, but most commonly, once you get to a level where you're not missing breaks, your surgery is good, you've done a lot, the one thing you can't overcome is PVR. PVR is, of course, a natural scarring reaction that occurs within the eye in response to both the retinal detachment and your surgery, and most of you will have seen at least some form of PVR, which, and I'll just show you this, I think it's at less than 1 minute. You get these very tough membranes, and you'll see what happens here is that the adherence is very clear because the retina moves a lot as you're trying to peel them. It comes off in big sheets. Some of it is residual vitreous cortex, and some of it is primary new retinal fibrosis in terms of reaction, and this peels off usually very nicely until you get to the old vitreous base. You can see the strength of the traction here. It's made this very big fold, and we're folding and peeling up here. So these peel away, and eventually when you peel away, you relieve the traction, sometimes requiring a retinectomy, and then you're able to reattach that retina and usually put silicone oil to hold it there for a lot longer. Peel the epiretinal membranes and star folds, retinectomy or buckle for shortening, and usually silicone oil with laser. Complications: endophthalmitis, hemorrhage, cataract, which is universal after vitrectomy surgery, especially if there is some kind of touch or the use of silicone oil. So retinal detachment has gone from being an untreatable blinding condition before 1920 and possibly well into the 60s and 70s, but it's now routinely treated with a greater than 85% success rate in well-trained specialty, in well-trained subspecialty. So, of course, we leave thanking not the speaker, but thanking Jules Golan, and next year I'm sure we'll all be celebrating the 100th anniversary. So that's retinal detachment. Time-wise, it's a quick rush through it, but I'm going to follow straight on, if that's okay with David, to talk about vitreous hemorrhage. Let me just find vitreous hemorrhage. Any ideas why? Just open?
It is open.
Oh, it is open. Okay, same thing. Okay, fine. Sorry. Oh, it's going to come onto this. Thank you very much. So, vitreous hemorrhage. So, retinal detachment is common, and probably vitreous hemorrhage is the second most common thing we spend our time dealing with. I just want to separate the cause of vitreous detachment, vitreous hemorrhage, which a lot of people worry about, and its management. Sometimes, even if you don't know the cause, you're still going to unfold the same management, which is to do with the person's vision and ultimately whether the hemorrhage is clearing or not, and therefore the need to clear it, and sometimes the need to clear it in order to find out what the cause was. And the management depends on vision, urgency if you know the cause, and then timing is often about the other eye and the disability. So history is important. Onset, sudden vision decrease with black dots and floaters. Everyone's seen a vitreous hemorrhage. The circumstance is important. If there's trauma, lifting, collapse, spontaneous, background history of diabetes, hypertension. So all of these things are clues to why you might get the vitreous hemorrhage. And of course, we want to know about previous episodes because recurrent vitreous hemorrhage, even if it's not severe, is an indication for surgery in diabetes. And the length of time it's been there tells you whether it's likely to clear in time. Anterior segment examination gives you some indications with hyphemas, subconjunctival hemorrhage and periorbital hemorrhages in skull fractures with trauma, presence of rubeosis, of course. So good clues to cause in the front of the eye, and it's critical to treat cause. For example, if you had a vitreous hemorrhage with rubeosis, you'd want to do some form of anti-VEGF injections before you went into the eye. How can we investigate vitreous hemorrhage when we can't see details? Of course, there are tests, ultrasound tests, blood tests, although we don't acutely do many blood tests for vitreous hemorrhage, CT scan in the case of trauma, and sometimes plain X-rays if there's a history that may allude to foreign body in the eye or orbit. Ultrasound is critical. That's the most common thing we do for vitreous hemorrhage. Confirms the blood and its density. Check for a posterior vitreous detachment and or retinal detachment, which changes the urgency. Gives sometimes a clue to etiology, and I'll show you that in the next slide. And it shows any abnormal structures to anticipate if you're going to operate. Here's an example of a diabetic with a dense vitreous hemorrhage, but showing all the various pegs associated with the NVEs. And suggesting that this is either tractional or active diabetic retinopathy, and it helps you make your decisions to treat. And of course, knowing where the optic nerve shadow and the movement of the detached retina allows you to identify whether the retina is attached behind the vitreous separation and whether what you're seeing moving is the posterior vitreous face or the retina to detach. So the ultrasound is fairly critical. It also shows tears in the case of a PVD and you're worried about a vitreous hemorrhage. What about the treatments? What can we do? Well, you can wait, and up to, depending on how much the patient is incapacitated or how tolerant they are, you can wait and watch, usually with serial ultrasounds. It's a nuisance for you and it's a nuisance for the patient, but you can avoid surgery and watch for retinal detachment or any serious sequelae. Urgent therapeutic vitrectomy with treatment. If you know there's rubeosis, the patient's a diabetic, the other eye's got proliferation, you would go in early to treat this following anti-VEGF injections. If there's a retinal detachment, you'd go in and treat early as well. An elective vitrectomy when the patient is either disabled or you think this is a posterior vitreous detachment. You haven't seen a tear in ultrasound, but you suspect that the most likely cause of the hemorrhage is a tear. Timing partly depends on whether it's unilateral or bilateral. Sometimes with something like Terson's, we will clear one eye just so the patient's functioning and then leave the other eye. The cause, of course, tells you timing, as I've just discussed, the state of the eye with rubeosis and pressure, and the density of the bleed. Sometimes you anticipate whether this is likely to clear or not. To treat, vitrectomy, of course, is the mainstay of treatment. There's no really other way of doing it. Once you're in, you diathermize the vessels that are bleeding, laser to ischemic areas, for the various things that cause ischemic drive, and you treat, of course, the retinal detachment. Trauma is always more complex because there's multiple components to it, including foreign bodies, retinal tears, incarcerations, and you treat as required. And very rarely is it secondary to infective disease, although very severe uveitis from infective causes can also lead to vitreous hemorrhage. So there's three mechanisms by which you can get blood into an eye. Firstly, there's abnormal vessels that are prone to bleeding. Secondly, there are normal vessels which have been torn. And thirdly, the blood has come from something in or next to the eye, which is not really a fault of the eye. So the first one is the one that's most familiar to us all. This is abnormal vessels within the eye, typically from neovascularization due to ischemia, and we all seen many causes of this. Here's diabetic retinopathy, areas of dropout, and adjacent areas of neovascularization, which always grow on the posterior vitreous face and therefore are prone to tractional hemorrhage. The second most common thing we'll all have seen is central retinal vein occlusions. Here, the neovascularization is often rubeotic first, but you can get NVE and slightly more rarely NVD. And here's what you see in very severe vein occlusions and sometimes diabetes with massive closure and florid rubeosis. And the third thing we see relatively commonly is ocular ischemic syndrome, where you've got, you may or may not have anything compromised within the eye, but what happens is the overall blood flow through the internal carotid system is compromised due to a significant stenosis. So all of these drive ischemia. Ischemia drives new vessel growth. Slightly rarer, sickle cell retinopathy, ROP, but not in the adult age group. And of course, florid proliferation from diabetes. This is not unfamiliar territory to you, but very common cause of vitreous hemorrhage. And it can be both subhyaloid and intravitreal. And in the subhyaloid ones, you can try laser. And here's one that Peter Hamilton lent me, where here's a very large subhyaloid hemorrhage, and you can laser in this very thick blood here. It drains away. But then they get on to get a generalized vitreous hemorrhage, and we don't do these very often now because surgery gives a quicker and cleaner route out. And of course, you treat the primary cause, which is sufficient laser. And should that fail, then you've got to go ahead and do vitrectomy. Based on the DVRS observation study, now remember, this is why you laser, they just watched patients with proliferative disease, 744 eyes with proliferative disease, laser at the physician's discretion with vitrectomy of not clearing, and after 2 years with no treatment, almost 50% of cases had lost vision. And this is the second thing they learned from that study. This is the observational arm, that stable extramacular tractional retinal detachments did not progress. So that's where you get this idea that you need to laser urgently from the DVRS report number 1 from the natural history arm. And then the report number 5 reported the outcomes from vitrectomy and laser. And it was demonstrated that there was a significant reduction in severe vision loss from early vitrectomy in type 1 diabetics, and it was equivocal in type 2, although we routinely do vitrectomies for them if it hasn't cleared within 3 to 6 months. So that's the source of the data for clearance of it. So in non-clearing vitreous hemorrhage, the indications in type 1 operate within 3 months, and in type 2 within 3 to 6 months. And this is modified by the state of the diabetes, especially if there's problems with IOP control and new vessels on the iris. The second indication in diabetes is a recurrent vitreous hemorrhage. This is because the source is tractional. You need to separate the vitreous from the vessel it's pulling on, and laser won't do that. The worst thing I see is young people who've been heavily over-lasered because of recurrent vitreous hemorrhage due to traction. You should always make some assessment of the activity of the vessels before you do more laser, and you need to think whether this might be tractional, and laser is not the solution, but surgery is. And in these cases, we'll sometimes do vitrectomy even if the blood has cleared based on the recurrent vitreous hemorrhage. So that's the first one, that's abnormal vessels that are prone to bleeding. The second one is normal vessels which rupture under abnormal stress. They can rupture when there's sufficient mechanical force, and this is retinal tears. We're most familiar with that. Retinal detachment, which goes with retinal tear, and vascular traction alone from posterior vitreous detachment. The second biggest cause is trauma, although it's less common than PVD. Terson syndrome, a bit rarer, and post-surgically. All of these, the vasculature can be normal and you still get a vitreous hemorrhage. So during a posterior vitreous detachment, as I said before, one of the strong areas of attachment is along the vessels and along the disc head. And you can get, during a normal vitreous separation, vitreous hemorrhage without a tear. So avulsion of peripheral vessels. But it's very hard to tell the difference between that and a tear, and we often will go to vitrectomy with someone who has no other explanation for a sudden and spontaneous vitreous hemorrhage and PVD on ultrasound. Of course, we see these cases where there's a bridging vessel, we know it's there, and even after laser around the tear, if we know there's a bridging vessel, they'll often hemorrhage later and end up having vitrectomy. Trauma, it's obvious how you can get blood in the eye from trauma, and trauma is very difficult to assess. And of course, don't forget, it's just not where you see the trauma, but there can be damage from into the orbit and into the posterior part of the globe as well. And we need to do indirect slit lamp examination, but also ultrasound, EUA, sometimes removing the blood from the conjunctiva first, and CT and X-ray. Finally, slightly rarer things, and this is normal vessels bleeding under abnormal circumstances. Terson syndrome, where you get an extravasation of blood into the vitreous, a source of triple layer hemorrhage. So you get vitreous hemorrhage, but you also get intra and subretinal hemorrhage associated with subarachnoid hemorrhage. And it's not an extension of the subarachnoid blood shooting down the optic nerve and exploding into the eye. It's to do with differences in pressures between the various spaces. So the blood is not an extension from the subarachnoid hemorrhage, and you get a sudden increase in intracranial pressure, and it can cause a differential in retinal venules to rupture. I've shown you one here which is fairly mild, because if I showed you one which had a vitreous hemorrhage, you wouldn't see anything. But you see here you can have subhyaloid hemorrhages as well as intraretinal hemorrhages, and it can be mild, moderate, and the ones we usually see are the ones with vitreous hemorrhage, which is severe. The final one is extension of blood from an adjacent source. And these are usually pathological vessels which are caused by systemic disease, such as retinal macroaneurysms, tumors, choroidal neovascularizations with breakthrough bleeds, such as polyps, and telangiectasia like Coates and FEVR. The macroaneurysms associated with hypertension, usually spontaneously thrombose if they hemorrhage, and we laser them if they leak. So here's a classic one. Once again, I'm showing you one that has the triple layer hemorrhage with very little vitreous hemorrhage, otherwise you don't see anything. You can demonstrate that on angiography and also on the area and the place of bleeding. This is a CNV with from polyps, a CNV or polyps, where you can get breakthrough bleeding once again. In these cases, I usually do the vitrectomy, telling the patient that they may get a small amount of temporal peripheral vision, and as long as they understand that, they're happy. Don't tell them they may get their vision back. They're always disappointed. And then various rarer causes of abnormal vessels. Here's the angiomas from von Hippel-Lindau. Tumors that come into the eye, these bleed, but rarely. And now we go to commonness. Which ones do you expect to see? In terms of abnormal vessels, the commonest by far is diabetes, followed by branch vein occlusions, and rarely sickle. In terms of ruptured normal vessels, retinal tears dominate, as does trauma, and retinal detachment, which is a subset of retinal tears. And in terms of blood from adjacent source, it's usually macroaneurysms and AMD or IPCV. And all of these things you're familiar with. If we group them all, the commonest cause of vitreous hemorrhage is diabetes, followed by vein occlusion, retinal tears, trauma, and this has been published. So just to remind you, vitreous hemorrhage, think about the cause, but don't be dominated by it. You need to make practical decisions of management based on vision, urgency of treating the cause if you found it, or urgency of suspected cause. And then the timing is dependent on multiple different issues. And then, of course, there are investigations. So you can see into the eye despite a vitreous hemorrhage, and you have to make some sort of presumptive diagnosis so you can move forward practically. We use ultrasound most commonly, but sometimes blood tests, CT scan, and plain X-rays. And management can be conservative, which involves serial ultrasounds until it clears, elective vitrectomy, early or delayed, chosen by the patient, or urgent therapeutic vitrectomy with treatment chosen by the surgeon. I think I've gone backwards. And the timing depends on whether it's unilateral or bilateral for practical purposes for the patient, the cause, the disease state, and the density of the bleed. Thank you.
Thank you very much. Any questions on those two subjects before we move on to vitreomacular interface abnormalities? David? It's a little bit late. We're all tired.